with us. We're delighted that you've joined, and we're so glad you could make time in your busy day to join this community of learning. We're very fortunate to have Dr. Karen Torres speak to us today about dementia and Parkinson's disease, clinical presentation and considerations in diverse rural communities. And we're also fortunate to have Dr. Christina Orby speak to us today with her case, bring forward a case presentation as well. So please rename yourself and tell us what clinic you're joining from. Put it in the chat if you're more than one person. Please mute your microphone when you're not speaking, and say your name when you speak, when you unmute. If you can, turn your video on. If you're unable, we understand, of course, but we enjoy seeing one another in this echo. And as I said, if there's several folks, do add those names into the chat, please. We have CME, and for all University of Washington faculty, staff, or students, you can enter through mobile text registration and sign in. If you haven't registered, send your email to this number you see on the screen. You should receive a response stating that your number has been updated. If you don't receive that message, then you can sign in here at uwcme.org. After registration, you text 10085 to the same number, and you should receive a response saying, thank you, we've recorded your attendance. Don't worry if you're not, because for all other attendees, your attendance will be recorded by the program manager. Thank you, Sammy. And also through Zoom Analytics. So please make sure that you're displaying your full name in order to capture that CME. Okay. Sammy can reach out if she has additional questions. So we do actually have a full case presentation, thankfully. So there is a number of really useful and helpful echoes through the University of Washington, University of Washington Traumatic Brain Injury Behavioral Health Echo on the first and third Fridays of each month. There's also an echo through addictions and psychiatry on Thursdays, and then a telebehavioral health training series on the third Friday through the Behavioral Health Institute. There's a fantastic, super helpful telephone consultation line, particularly for people who are needing guidance around complex pain medications at high dose and high dose opioids. You can see the number here. And then there's a CME accredited case conference series, UW Telepain, which meets on Wednesdays. So you can participate in any of these. They're all CME accredited. Additionally, there's the University of Washington Psychiatry Grand Rounds archive, and you can view a number of really amazing talks, grand rounds there as well. Okay, so in all of our discussions, we of course protect private health information. We don't display or reveal or say anything that could identify patients or family members. All sessions are recorded and available on our website, and please do complete that 1 minute. It's literally 1 minute post-session survey, because it helps us to continue to improve and iterate, and be responsive to what you guys want and what would be helpful and supportive. We talked about CME. We have no financial disclosures, neither the speakers nor the facilitators, nor those who are putting this together, nor the hub. So all relevant if there are any ever financial relationships to disclose, they are very, very serious, mitigated carefully. So here's our hub team smiling, both in the picture on the screen and right now in real time with you in this virtual space. Here's all of you in the state of Washington who are participating throughout the state of Washington. We want to continue to grow. We've provided almost 1,500 instructional hours since the inception in June 2020. 70% of survey respondents say that they would incorporate a change in practice based on the rich and useful learnings. And we really want to continue to grow. So if you have a colleague or somebody who you think would find this of value, do share that we're here on the second and fourth Friday. So now it's with great pleasure that we welcome Dr. Karen Torres. She's a neuropsychologist at University of Washington, and she will speak to us on dementia and Parkinson's disease, clinical presentation and considerations in diverse rural communities. Thank you so much, Karen, for being here, and we're excited to learn more from you.
All right. Does this look pretty good? Okay. Well, thank you very much for the invitation to come here to Project Echo on this Friday and talk about Parkinson's disease and dementia. I'm a neuropsychologist, and my primary clinic duties are to evaluate patients with movement disorders who are interested in going through deep brain stimulation, but also who present with an array of cognitive issues. So the talk today, I'm hoping to get through some information regarding Parkinson's disease, not only its clinical presentation, but how quickly it is growing worldwide. As a neuropsychologist, my area of interest is to evaluate cognitive and psychiatric manifestations of neurodegenerative diseases. So we'll talk about how that presents in Parkinson's disease dementia. And because a lot of my efforts outside of clinic and research have been related to investigating Parkinson's disease and Hispanic and Latino communities, I thought I'd talk about how perhaps those individuals living in rural communities may be at increased risk for developing Parkinson's disease because of their environment. So Parkinson's disease is the second leading neurodegenerative disease after Alzheimer's disease. It's the fastest growing neurological disorder in the world. Currently, there's estimated to be 8.5 million folks with Parkinson's disease in the world, and by 2030, which is in a few years, it's estimated to rise to 12 million. The age of onset typically is between the ages of 40 and 70. It's an insidious progression, and the course can be anywhere between 5 to 20 years. But of course, there's individuals who live for several decades with the disease as well. Men are more likely than women to develop Parkinson's disease. Most cases of Parkinson's disease do not have an identifiable familial link or a genetic mutation. It's estimated that between 5 to 15% of cases have a genetic mutation related to Parkinson's disease. We know that environmental exposures increase risk for Parkinson's, and some studies have shown that people who work or live close to environments that use pesticides, herbicides, their risk for developing Parkinson's disease may increase by 50%. Caucasian and Hispanic Latino men specifically are twice as likely to develop Parkinson's disease, and the prevalence in Latin America has been found to be much higher than that globally. So what do we know about the pathology of what happens in Parkinson's disease? Classically, and I say classically because this is an ever-changing area of study, but what we know about idiopathic Parkinson's disease, that it's a degenerative disorder that is caused by the loss of dopaminergic neurons in this part of the brain called the substantia nigra pars compacta, which, in this image here, we see how asymmetric it presents, meaning that on the left side, we see a very pigmented substantia nigra, meaning there's still a lot of dopamine there. Whereas on the right side, it's quite pale and depleted, meaning that dopamine has deteriorated in that area of the brain. But we also know that Lewy body accumulations in the basal ganglia, but also in the cortex, accumulates in the brain of people with Parkinson's disease, and the primary protein is alpha-synuclein. And so the presentation of Parkinson's disease is quite varied and quite complex. No two people with Parkinson's disease experience the same symptoms or experience a similar rate of progression or symptom severity. It's a very varied disease. So I like to, this iceberg of Parkinson's disease can help elucidate, what people experience with the disease. Classically, what most people know about Parkinson's disease are the motor symptoms. We have tremor, rigidity, slow movements, etc. But what's under the surface is this constellation of non-motor symptoms that are just as impactful to the patient with Parkinson's disease. And this includes a wide-ranging, multi-systemic involvement of symptoms where there's constipation, there's cognitive impairment, there's psychiatric symptoms, sleep issues, etc. So it is a very, very complex disease. Classically, the motor symptoms of Parkinson's disease have been identified to be tremor, and it's tremor that typically presents on one side of the body. And if it's in one of the extremities, it's been known to be present at rest, meaning when someone is in a relaxed state. However, that definition has changed over time because we know that there are people with Parkinson's disease who also exhibit tremors at posture or at action. People with Parkinson's disease also classically demonstrate slow movements, and these are slow movements in initiating movement, getting out of a chair, for example. The range of movement in their faces is restricted. Their writing is smaller. Their voice may get much lower, and there's also rigidity. Resistance of muscle movement in the body. So these are the more classic motor symptoms for which dopamine is, impacting on an individual. But the non-motor symptoms of Parkinson's disease are also involve other symptoms and a lot of other neurotransmitters. So there's cognitive issues that occur in Parkinson's disease that can go from subjective cognitive impairment to documented cognitive impairment to dementia. We know that autonomic disturbances are quite prevalent in people with Parkinson's disease, and some of these may be present years, if not decades, before the onset of motor symptoms. Things like constipation, erectile dysfunction, a decrease or loss of sense of smell, sleep disturbances like REM sleep behaviors, which is when people are acting out their dreams, they're kicking, they're screaming, they're hollering all in sleep. They're whacking their bedmate next to them. That has also been known to be present for years, if not decades, before the onset of motor symptoms, as well as mood symptoms, primarily depression and anxiety. Again, present for years, if not decades before the onset of motor symptoms, which leads to this understanding that there is a prodromal state that exists in Parkinson's disease, a stage where there are a constellation of autonomic, psychiatric, and cognitive symptoms that have been brewing, that have been progressing in the years leading up to when the motor symptoms are first noticed and subsequently when Parkinson's disease is diagnosed. So, for example, people with Parkinson's disease, 20 to 30% of them may be diagnosed already with mild neurocognitive disorder at the time that they've been diagnosed with Parkinson's disease. And some studies have tied this to an estimate that up to 60% of the dopaminergic system has depleted by the time motor symptoms in Parkinson's disease begins. So that is quite a profound degradation of the system that occurs before the onset of motor symptoms and can help explain perhaps the surfacing of these prodromal symptoms in the years leading up to the disease itself. So as far as, the neuropsychological functioning of people with Parkinson's disease, it's also quite complex. As we see here from this figure, people with Parkinson's disease, their cognitive abilities, can be wide-ranging. Some people may have subjective cognitive complaints or with no documented cognitive decline over the course of their disease. That's less common. We have also people who may initially be diagnosed with mild cognitive impairment, but then revert to normal cognition, and a few years later be diagnosed with mild cognitive impairment and subsequently dementia. So there may be a fluctuation in cognitive impairment that occurs that could be related to, for example, medication. If someone is diagnosed with Parkinson's disease, but they also have cognitive difficulties at the time of diagnosis, medications that are known to promote dopamine or that are meant to improve motor functioning can subsequently also improve cognitive abilities. People are moving better, their thinking is clearer, and so those are the folks that may revert to normal cognition, but eventually as the disease progresses, they move on to mild cognitive impairment again, and then dementia. Another subset of people, they develop early mild cognitive impairment, and it's slowly progressive through the course of their life and never really converts to dementia. Other people are diagnosed with mild cognitive impairment and have a normal progression or conversion to Parkinson's disease dementia. There's a subset of people who are diagnosed with mild cognitive impairment and then rapidly progress to Parkinson's disease dementia. So it's quite varied. The cognitive spectrum of how someone experiences cognitive changes, and that changes over time, it's quite different from person to person. So when we talk about the subset of folks who at time of diagnosis of Parkinson's disease are also diagnosed with mild cognitive impairment, among the earliest cognitive domains that are impacted or are noticed are executive function. And I see a lot of patients who are still working, they're relatively younger, are diagnosed with Parkinson's disease, but they cannot put their finger on exactly how much difficulties they're having or in what area. So they're talking about how they're becoming less efficient at work. It takes them a longer amount of time to get their work done, or they're really being hampered down by distractions, and it's really tough for them to get back on track, or organization is more difficult. So these are among the earliest signs of cognitive difficulties that we notice in this subset of people. But are these mild executive difficulties captured on neuropsychological testing? Not necessarily. For some aspects of neuropsychological testing, these patients may perform well on the measures that we give them. My area of research in the last few years has focused on looking at more of the qualitative nature of neuropsychological functioning. And so in people with Parkinson's disease, looking at, for example, the types of errors that they make on testing. Are they perseverative? Are they set loss errors? What approach are they using to learn a list of words, for example? And so it's most of these more subtle executive difficulties that may be at the prodrome or at the early stage of this disease. So it's there, and it may be very mild at the beginning, but it's noticeable to these patients. Among the earliest cognitive domains affected by Parkinson's disease, because dopamine and its depletion is well known to be impacted by Parkinson's disease, dopamine is important for this frontal lobe striatal circuit, going from the basal ganglia to the prefrontal cortex, where executive functioning lives, phonological fluency, generating words that begin with a phonemic sound. Memory retrieval may be impacted in Parkinson's disease, But unlike Alzheimer's disease, it's not an amnestic type of memory difficulty. It's memory difficulties related to spontaneously coming up with the information that was previously learned, having more difficulty with that, but they're better able to recognize this information and are helped with by clues that are given or cueing that is given to them. A separate type of cognitive difficulties that may be occurring early on in Parkinson's disease is those abilities that affect the posterior cortex, the back part of one's brain. And these are all visual spatial difficulties and abilities, synthesizing information, organizing visual information in front of them. So if you ask them to, copy the ray complex figure, there may be a lot of difficulty with organizing, initiating, and planning in these areas as well. So who's at risk for cognitive decline if you have Parkinson's disease? Certainly if you're male, if you're older, at the time of symptom onset, of motor symptom onset, if you have a history of experiencing hallucinations and depression, you're at higher risk. If your motor presentation is not necessarily the tremor predominant presentation, so if it's more rigidity, if the symptoms affect more of the axial parts of your body, like your neck, for example, they may be more susceptible to going on to develop severe cognitive impairment. And certainly a history of REM sleep behavior disorder puts you at big risk for future cognitive decline, because REM sleep behavior disorders have been associated with frontal striatal circuits, posterior cortical cognitive difficulties, and a high conversion eventually to Parkinson's disease dementia. So when it comes to the specific types of cognitive impairment in Parkinson's disease, we know mild neurocognitive disorder, formerly known as mild cognitive impairment, and I still use those two things interchangeably, but mild cognitive impairment, again, present in up to 30% of people with Parkinson's disease at diagnosis. It's a modest cognitive decline from pre-morbid estimates. So there has to be a documentation that there is a decline in these abilities on testing, for example, that can cover one or multiple cognitive domains. Importantly, for it to be a mild neurocognitive disorder, people should still be able to perform the instrumental activities of daily living, manage their medications, their finances, drive okay, still be able to work, etc. And these cognitive difficulties are not better explained by other etiologies. The conversion to dementia from Parkinson's disease, mild cognitive impairment to dementia, one cohort study currently is estimating that 60% of people who are diagnosed with mild neurocognitive disorder go on to convert to dementia 5 years after their diagnosis. However, as I previously mentioned, there is a subset of folks who go on to go from mild neurocognitive disorder back to normal cognition, but then back to mild neurocognitive disorder and then dementia. So it can be quite variable. The Movement Disorder Society has specific criteria for mild cognitive impairment due to more Parkinson's disease, and they have two levels. Level 1 is restricted to having more of an abbreviated assessment when a more comprehensive neuropsychological assessment isn't available. This abbreviated assessment can include that administration of a cognitive screen like the MoCA, and seeing impairment in cognitive domains. However, level 1 assessments alone have been shown to be more linked to the diagnosis of mild neurocognitive disorder and then reverting to normal cognition. So it may not be sufficient for that diagnosis, whereas a level 2 assessment has a much more comprehensive evaluation of cognitive abilities across domains of attention, executive function, memory, etc. There has to be impairment on these tests, two tests in one domain or one test in two different domains, and a documented score 1 to 2 standard deviations below the norm. And especially, serial testing, and, a decline from premorbid function is helpful in differentiating that. As far as the specific classifications of mild cognitive impairment, it could be either single domain, meaning only one domain is affected, let's say executive function, or more commonly, it's multiple domains. So it can be executive function, it can be attention and processing speed, etc. So there's two primary subtypes with Parkinson's disease, mild cognitive impairment. The dual syndrome hypothesis proposes that Parkinson's disease related cognitive decline is likely caused by two primary issues: dopamine degradation or depletion, leading to this type of frontal lobe and subcortical system deficits, so executive function, processing speed, but also a second syndrome can be more widespread cortical atrophy or buildup of the alpha synuclein and tau, which affects visual spatial skills, language, and memory. So much more of a global and cortical involvement of cognitive impairment. So major neurocognitive disorder, on the other hand, or dementia, you have to demonstrate a significant cognitive decline from premorbid baseline on neuropsychological testing. People have to be concerned about this cognitive decline. So typically family members or friends. And what differentiates mild from major neurocognitive disorder that in major neurocognitive disorder, there is a difficulty with independent living. So meaning that people are having now much more difficulty with managing medication, managing finances, etc. We need to make sure that this cognitive impairment is not being due to other etiologies or causes, such as delirium from a UTI, for example. And the majority of Parkinson's disease patients, ranging from 50 to 80%, will go on to develop a major neurocognitive disorder due to Parkinson's disease between 5 to 20 years after diagnosis. So the Movement Disorder Society also has 2 levels of criteria for diagnosing dementia and Parkinson's disease. Level 1, again, when a comprehensive neuropsychological evaluation isn't available. However, people, it can be diagnosed if, one, the person meets criteria for Parkinson's disease. Parkinson's disease symptoms developed prior to the onset of dementia. On a cognitive screen, someone performs below normal limits, and cognitive deficits are affecting independent living that are observable by someone in their life. And it's not caused by any other etiology. Whereas a Level 2 comprehensive assessment of dementia will include a full neuropsychological evaluation that assesses global cognition, the subcortical and frontal lobe features of Parkinson's disease, so executive functioning, complex attention, processing speed, but also we need to have test of cortical functioning, including language, memory, visual spatial abilities, etc. And there are neuropsychiatric features that are associated with Parkinson's disease, dementia, that can include apathy, depression, hallucinations, and other forms of psychosis as well. So a word about Parkinson's disease dementia versus dementia with Lewy bodies. So there has been, traditionally a 1-year rule that distinguishes dementia with Lewy bodies from PDD. So if the dementia occurs more than 1 year after the diagnosis of Parkinson's disease, then the diagnosis is Parkinson's disease dementia. Whereas if the Parkinson's symptoms occur after or simultaneously with dementia, then it's classified as dementia with Lewy bodies. So it's dependent on which pattern of symptoms presented first. Distinct profiles between Parkinson's disease dementia and dementia with Lewy bodies. I think earlier in the course of these diseases, they're distinguishable, but as the diseases progress, that is less so the case. So initially, people with Parkinson's disease dementia have the executive functioning difficulties, visual spatial and processing speed difficulties on testing that are observed. People with dementia with Lewy bodies have visual spatial deficits, but more prominent memory difficulties and language difficulties, which we don't typically see with Parkinson's disease. However, this profile is very similar to the posterior subtype of Parkinson's disease, with the involvement of visual spatial and memory abilities. And so, it is argued that as these diseases progress, they certainly start becoming a lot more similar as far as the types of cognitive difficulties that they present with, which emphasizes the importance of, having a good chronology of onset of symptoms, what came first, what came afterwards, etc. Parkinson's disease dementia, it compromises quality of life. People lose their independence, not only, mentally from cognitive abilities, but also motorically. They become dependent on care partners for multiple symptoms, not just cognitive impairment, but motor impairment, autonomic impairment, psychiatric issues, and so forth. And so it can be very, very stressful for care partners. It's very expensive, and treating these multiple symptoms can be very, very challenging. As far as management of cognitive impairment in Parkinson's disease, medication, has been modestly shown to help improve cognition in mild to moderate Parkinson's disease dementia, but there's no medication for the MCI stage of Parkinson's disease. Cognitive intervention and certainly physical exercise has been shown to modestly help improve cognition in Parkinson's disease, but it is very modest. Alternatively, the indirect strategies for managing cognitive impairment in Parkinson's disease is dealing with the comorbidities, vascular diseases like type 1 diabetes, blood pressure issues, certainly obstructive sleep apnea, if suspected or if present, needs to be assessed and treated because it definitely can impact cognitive function. But comorbid depression, anxiety, and apathy, and sleep difficulties are known to compound on the cognitive difficulties that are already present from the disease itself. So working to reduce these comorbidities is very important. So not only do we have cognitive impairment in dementia, but there's also an exacerbation or onset of several psychiatric symptoms that occur in Parkinson's disease dementia. So people with Parkinson's, at a baseline, 50 to 60% deal with depression. Depression symptoms of sadness, feeling pessimistic, feeling a lot of guilt and worthlessness because they feel like burdens to their family members who are taking care of them. Suicidality is something that is present in some people with Parkinson's disease. And depression can definitely amplify fatigue and reduces motivation, which leads to further dependence on a family member about, you know, doing things outside of the home. Treatments for depression and Parkinson's disease, SSRIs have been known to be very effective in improving symptoms, as has psychotherapy. Apathy is a syndrome that is completely separate from depression and Parkinson's disease, and it's present in up to 40% of people. Apathy includes more of a lack of motivation, a lack of interest or engagement in certainly in activities they used to enjoy, but also can bleed onto interest in the family and their partner and doing things outside of the home. So they become more sedentary, more prone to staying at home, watching television, being away from other people. And if the apathy is severe enough, they become dependent on others for prompting them to getting up and getting dressed, taking a shower, for example. And so while there are some treatments that can help reduce the apathy in Parkinson's disease, some studies have shown that SSRI specifically can increase apathy in people with Parkinson's disease. So there's this fine line of, treating the depression, but also in treating the depression, are you increasing the apathy? And it's just, a very, very complex approach. And apathy, other than medications, there haven't been a lot of other treatment strategies that have been shown to be helpful. Anxiety is also present in approximately 50% of people with Parkinson's disease. And this anxiety is often takes the quality of more of an agoraphobic type of anxiety, meaning that there is this reluctance or this fear about leaving the home. And this is not surprising in people with Parkinson's disease, because when they take their medications and their medications take effect, they're able to move more, they're able to get out of a chair, they're able to walk, etc. But they also live in fear of the medication wearing off. And so when the medication wears off, they're back to feeling frozen in their bodies. They can't move with as well as with medication. And so it's this dread that occurs. The dread of wearing off in public, that may be embarrassing, that may prevent them, for example, from being able to drive home from the grocery store. And so social isolation becomes prominent again. And dependence on care partners becomes prominent when there's a lot of anxiety. Medications and psychotherapy have been shown to be efficacious in treating anxiety in Parkinson's disease. Impulse control disorders in Parkinson's disease are probably one of the most challenging behaviors, especially, someone who's been living with Parkinson's disease for several years. We see that with increased medications, impulse control disorders may come to the fore, too much dopamine. It can be embarrassing if the compulsive symptoms are related to excessive spending, gambling, hypersexuality. It puts a stress on the family members, financial duress, relational duress with your partner. And it's embarrassing to talk to providers. But certainly impulse control disorders that can help, that can be decreased, are just generally looking at medication. Decreasing medication, especially dopaminergic medications, can help alleviate some of these impulse control disorders. And also, if someone has had deep brain stimulation, investigating the stimulation parameters can help alleviate some of those impulse control disorders. Psychosis can be brought on by medication used to treat Parkinson's disease, or by the disease and the course of the disease itself. 50% of people with Parkinson's can develop psychosis 5 to 10 years after diagnosis. The most common type of psychosis are visual hallucinations. So seeing animals scurrying around the floor, figures of people in their homes, etc. Delusions are frequent. Delusions of jealousy, of infidelity of a partner, of safety or persecution, intruders coming into the home, kind of looking outside the window, seeing what the neighbors are doing, tends to be much more common. But there is treatment that has been successful in treating the psychosis that occurs in Parkinson's disease. So, given how Parkinson's disease is a very complex disease, it's multisystemic, a lot of different complications that happened. It is worth considering how such a complex disease can affect communities that may not have access to specialty care for Parkinson's disease. I read somewhere that in the United States, there's only 600 movement disorder neurologists in practice, and the majority of them are in more urban settings. So something worth considering, given how quickly Parkinson's disease is increasing worldwide. So with that, we have to go back and briefly discuss the causes of Parkinson's disease. So 5 to 15% of cases are due to genetic causes or identified genetic causes. So just because someone goes through genetic testing and there's no genetic cause identified for their Parkinson's doesn't mean it doesn't exist. It means that possibly it's yet to be identified. However, we do know that environmental risk factors increase Parkinson's disease significantly by 50% if you're someone who works or lives in an environment where pesticides and herbicides are regularly used. But we know that air pollution, Agent Orange, heavy metals related to a profession like welding, being access to well water and traumatic brain injury are also environmental risk factors for Parkinson's disease. But if we look at pesticides, herbicides specifically, as of 2018, Washington State had a rate of Parkinson's disease 14% higher than the national average, believed to be related to our agricultural economy in central and eastern regions of the state. In 2022, the EPA finally banned this herbicide that has been used in apple orchards in central Washington since the early 1960s because it was demonstrated to be associated with developing Parkinson's disease, a relationship, not a cause, but there's a relationship. Younger onset of Parkinson's disease has been associated with environmental risk factors like the ones I previously mentioned. The death rate in Parkinson's disease in Washington State has slowly increased over the years. It was the highest in 2021. We still do not have data from the years since then. But Washington State, you see, it's one of the states that is very deep in purple, meaning the highest death rates, and it's number 15 out of all 50 states as far as the mortality from Parkinson's disease. If we look at paraquat, for example, which is an herbicide, it's an herbicide that's continued to be used in the US while it's been banned in 60 other countries because of a relationship or association with Parkinson's disease or Parkinsonism. In animal models, paraquat has been shown to degrade the dopaminergic system, leads to the accumulation of alpha-synuclein. In rural California, this study just came out earlier this year about paraquat in Central Valley, California, and PD was twice as likely to occur in people who live in ambient paraquat, meaning not only do you work the fields, but living in those surrounding areas. And if we see this table here, who are the people who live in these top 5 regions where paraquat was sprayed in Central California? They're Latinos, 87% in Wasco County. And so Latinos who live in these rural communities are at increased risk for developing Parkinson's disease. And there are health disparities that exist in Parkinson's disease among Hispanic Latino individuals. They tend to experience more severe motor symptoms and take less medication. And this could be related to access to care or their own beliefs about medications. Latinos tend to experience greater depressive and psychosis symptoms. They have a worse overall health quality of life. Their perception of discrimination worsens the symptoms of Parkinson's disease. A good proportion of these folks, especially in rural California, have been shown to have a history of working in farming communities. Latinos may present 5 years younger and with more severe symptoms than their Caucasian counterparts. Latinos are suboptimally treated with medication. They're younger at the time of their death from Parkinson's disease. They're less likely to use therapies that help with the quality of life with Parkinson's disease, so physical and speech and language therapies. They have overall lower cognitive scores. Although they may exhibit more depression symptoms, they're less likely to be prescribed antidepressant medications. And this could be due to limited access to neurology care, specialists, language, literacy barriers, financial barriers that are prevalent. And this undoubtedly leads to exacerbation of their symptoms and the progression of the disease in their lives. When it comes to dementia in Latinos with Parkinson's, older age of onset, REM sleep behavior disorders, the atypical motor presentation has all been linked to higher rates of dementia in Latinos, and certainly lower MoCA scores due to lower levels of education and therefore cognitive reserve, higher level of mood symptoms, all contribute to a higher likelihood of going on to develop dementia in this community. There are challenges with diagnosing dementia in this community. There's a lot of shame and discomfort to talk about, especially the non-motor symptoms of Parkinson's disease. So people with Parkinson's disease, who are Latino, may wait a long time before they go to the doctor and talk about these symptoms that may be shameful. The community may see Parkinson's disease as part of the normal aging process. It just something that happens. But definitely lower levels of education and literacy can help, can contribute to, having a harder time diagnosing levels of dementia. And just to finish up, barriers to care in these rural Latino communities, language, lower education, lack of access, all of it contributes to how Parkinson's disease not only presents, but is diagnosed and is treated in this community. Just to wrap up, Parkinson's disease is a rapidly growing neurodegenerative disease. It's very complex, it's multisystemic. The psychiatric and cognitive impairment that occurs from Parkinson's disease is quite common in this disease. Rural communities have an increased risk for developing the disease due to their environmental surroundings. And with few movement disorder specialists, there are challenges in the management of this disease. All right. Thank you very much.
Thank you. What an outstanding talk about Parkinson's disease and dementia and the non-motor symptoms and the environmental risks that disproportionately affect Hispanic and Latina populations. And we have time for one question before we move on to the case presentation. Thank you again, Dr. Karen Torres. Really fantastic. And I know people are going to return to the slides to review and can watch this again because you really covered so much information. Is there one pressing question before we, and yes, and you see her
And
email there,
yes,
so.
I did. It's very, very dense. And please email me if you have any questions, discussions, collaborate on ideas. I'm open to all of it. So yeah.
So much information. So Trang, yeah, please. And then we'll move on to the case presentation. Thanks, Trang.
Yeah, great presentation. Thank you. I learned a lot. I have a question about Nuplazid. It's such an expensive medication, and have you seen people using it and how effective it is?
So based on the patients that I've seen, it's been very effective, and it's preferred versus something like clozapine, which requires the weekly labs to check on how if it's compromising other aspects of their functioning. So from the providers that I've seen, they do use it, and it's very effective.
Hmm.
Do you know if insurance pays for that?
I do not know that.
Thank you.
Thank you. Okay, and thanks again. And we are now shifting gears to have Dr. Christina Orby, who's a geriatric fellow with Swedish, bring forth a case presentation. Thank you so much, Christina.
Thank you so much for having me. So yeah, my name is Christina Orby. I'm a geriatric fellow at Swedish First Hill, and I am presenting this case for a patient that I saw in geriatric assessment clinic. And just to provide some background, as part of our fellowship, we have geriatric assessment clinic that happens once a week, and it's a consult-based clinic where patients and their families will spend up to like 2 hours with us. So we get a lot of time to get history and symptoms, and they also meet with an interdisciplinary team, which includes geriatric fellows, family med residents, behavioral health, social work, and pharmacy. And so we get to have a quite a comprehensive view of the patients. And so this was a patient that I just kept thinking about for like the weeks following seeing her, because I just had so many questions about her assessment and what to make of the symptoms that she was having. So I'm happy to share it with you all today. So I saw this patient, she's 77 years old. She comes back to geriatric assessment clinic with her son for follow-up of cognitive evaluation and new hallucinations. She was previously seen in our geri assessment clinic in June of 2021. And at that appointment, she had a RUDOS performed with a score of 18 out of 30. And at the time of the assessment, she did not have any functional decline and was still independent with all of her ADLs and IADLs. And so she was given a diagnosis of MCI with the etiology thought to be due to vascular etiology. So with regards to this new complaint of hallucinations, there had been varying reports of the clinical history of these hallucinations. In chart review, in preparation for the visit, I saw that she had a visit in March with her daughter, with her primary care doctor, about hallucinations that had been going on for 6 months. She lives with her daughter. She's lived with her daughter for like, I think her whole adult life. And so this is like the daughter knows the clinical history very well. And what is described in the note is that the patient was hearing music and seeing strangers and talking to them. And she was so distressed by these visualizations that she like locked herself in a room and wouldn't come out and couldn't be reassured. But when I had my own history taken with her in April, like the following month, she tells me that the hallucinations were only going on for 1 month. She denied any auditory hallucinations and described visual hallucinations that kind of occurred in her peripheral vision. She had this sense of like seeing bugs and snails on the ground. And then she did have one hallucination as she was falling asleep where there was she describes like a specter or a figure in her room, and that was very distressing to her. She believes that the reason for this hallucination is related to stress. She identified that a particular stressor for her was the ongoing conflict in Ethiopia, and she has had multiple family members affected by the ongoing conflict. For past medical history, she has a history of macular degeneration, which is quite significant. She's I think legally blind, also with a history of glaucoma. She's had a history of a right MCA stroke and has residual left-sided weakness, has a history of AFib, non-alcoholic fatty liver disease, hypertension, also with hearing impairment, but she doesn't wear hearing aids, and she was given a diagnosis of MCI in 2021. She had no psychiatric history, no delusions in the past, no mood disorders in the past either. For social history, she immigrated from Ethiopia about 30 years ago, and in the last 30 years, she had been splitting time living with her daughter in Seattle and then going back to Ethiopia. She lives in a multi-generational home with her daughter, her grandchildren, and a domestic worker who's kind of a family friend. They were previously based in Seattle, but the daughter had a new job and relocated to Portland. And so the patient continues to come to Seattle to visit her sons. She has 2 other sons in the city. And then she also gets all of her medical care in Seattle, though she's spending the majority of her time in Portland now. And with regards to the domestic worker, this is someone, a family friend who helps with like housekeeping, chores, groceries, just kind of an all hands on deck approach to their kind of communal living situation. For our visit, we had an interpreter who was so valuable in providing additional cultural context. The interpreter let me know that the way that my patient was dressed meant that she was a religious figure in her community. She was wearing this like lovely white dress with a headpiece, and that felt important for the interpreter to name and for me to be aware of. And then also she provided history that she did not receive any schooling. For medication, she is on apixaban, atorvastatin. She has a number of like bowel reg meds including bisacodyl, Miralax, and Senna. She's on diltiazem, and she has a number of eye drops for management of her glaucoma and her macular degeneration. Some workup that we have included a brain MRI. This was actually obtained after I saw her in geriatric assessment. So like some highlights from the MRI brain was that her brain parenchyma showed a large area of chronic encephalomalacia along portions of the lateral right frontal lobe, and some periventricular white matter changes. This was also present on an MRI in 2019. She also showed evidence of an old MCA infarct and some small left cerebellar infarcts as well, but nothing acute. The reason that I recommended getting an MRI was to the PCP was because of these new hallucinations and see if there was any change in her brain anatomy, and there really wasn't a great explanation. For labs, she had labs that were all normal. She had a normal CBC, CMP, TSH, vitamin D, B12. I think in the past remote past after her first GERI assessment visit, I think we also did RPR and HIV, and those were also negative. So as far as the cognitive assessment that we did in the clinic, actually tell you about her historical cognitive assessment. So she had a RUDAS done in June of 2021. Her score was 18 out of 30. I reviewed the score sheet from her RUDAS, and they noted in the visual construction score, there wasn't a score, but just said vision. And it was not clear to me if that meant to signify that the patient couldn't see the drawing, but she was still scored out of 30. Even though she couldn't really participate in that part of the examination. So when I administered the RUDAS, I gave her, her score was 24 to 26, and I'll explain why this range of scores in a minute, and then out of 27 score, because I didn't count the visual construction portion. We also did a geriatric depression screener, which was 0. Her CATs showed that she was independent for her ADLs, and then her lot-in showed that she had some dependence in her IADLs, but this is more of a function of her living in a multi-generational home, not really because of any cognitive impairment that she wasn't participating in her IADLs, but just the fact that a lot of the housekeeping and managing bills and going shopping, transportation, those were kind of delegated to other members of the family. On her physical exam, she was pretty benign. She ambulated with a single point cane on the left, but her gait otherwise was normal. her motor and sensation exam was grossly intact, no tremor, resting, or intention. She did not have any bradykinesia. She had a very expressive face. Her mood was quite pleasant. She was interactive and telling jokes during the exam, not withdrawn, not like responding to internal stimuli. So in terms of her performance on the cognitive assessment, things that worked well for us, we had an in-person Amharic interpreter. Because of her hearing impairment, we had her wear pocket talkers, and that she said that she could hear the prompts quite well, and she had good effort to participate. But it was at multiple points during the exam, she had limited buy-in for different parts of the exam. So like for the first part of the RUDAS, it asks you to remember a grocery list of 4 items. You ask the patient to repeat it 4 times to see if they can learn these 4 words, and then you have them repeat it at the end to see if they retain that those 4 words. And she really just like wasn't bought into the idea that we're going to imagine and to go shopping. She's like, I never go shopping. That's not my job. I think kind of referring again to how in her multi-generational home, she's not the one responsible for going shopping. And the interpreter also provided cultural context that like, because of her figure as a religious figure, like this shopping and doing these kinds of errands aren't really typical for her. And so I, instead of making her do the remembering the grocery list, I instead had her remember 4 items that she needed to pack for a trip. I chose that because she travels between Seattle and Portland with regular frequency. And so I had her remember shirt, comb, soap, and shoes, I think. And she was able to remember all 4 of those items in the immediate recall 3 out of 3 times, and then she was also able to remember them at the end of the testing, and so I rewarded her full points for that portion of the test because I felt like it got to the spirit of trying to recall 4 words. And then later in the RUDAS assessment, there's a part that's testing fluency and a patient's ability to name animals. And so when I gave this prompt, the interpreter provided the context that in Ethiopia, like when I asked someone to name animals, they would only, it would be abnormal for someone to generate a list of like zoo animals, but they would only list livestock animals, and there's a limited number of those. And so the interpreter felt like that wasn't a great prompt. I still had her do that prompt, and she was able to name 6 animals. But in order to try to provide a little bit more cultural accommodation, I had her ask, or I had her tell me different dishes, like meals that she would be common for her. And she was able to tell me 8 of those. And each of those meals were like distinct meals, not ingredients, like fully prepared dishes. And so I felt that kind of, if the prompt wasn't really culturally congruent, then I tried to give her a prompt that would get to the spirit of her being able to give her ample opportunity to give a wide breadth of answers. So what do I do with this assessment, which is kind of like what I wrestled with for the after the visit. So I think there's multiple layers of like why this is not really a valid test administration. One is that because she has visual impairment, she couldn't even participate in the visual construction portion of the testing, and RUDAS hasn't been validated for patients with visual impairment. So ultimately, like even by that metric, I don't think this was like we could say that this was valid testing. And then you know, the RUDAS also wasn't validated for all these like different accommodations that I gave to the patient. But if I were to score her strictly, so like without any cultural accommodation and like just did her score based on animals, her score would be 24 out of 27. And if I scored her flexibility flexibly, allowing her to use food dishes, her score would be 26 out of 27. And a RUDAS score greater than 22 is normal or not abnormal. So both of these still kind of put her in the normal cognition range. And then also just another assessment piece that I had challenges with was really getting at the functional assessment in the context of her living in a multi-generational home. You know, when I was hearing her like tell me that she's like, oh, I don't do bills, I don't do shopping, I always try to follow up that answer with the why. Like, is it because it's too complicated of a task? Is it that you don't remember what you need to go, like what the steps needed to do that? And it took a while for us to realize that, like, it's not that she can't do those things. It's just that the structure of her family she doesn't need to be doing those things. So my overall assessment for her after our Jerry visit was, from a cognitive standpoint, it was my clinical impression that she had normal cognition, which represented a reversal of her MCI from previous. And then with regards to the hallucinations differentials, highest on my differential was Charles Bonnet, just because of her visual impairment. She does have an ophthalmologist that she sees with regular frequency, and I reached out to him thinking about if he thinks that this could be, if Charles Bonnet could be contributing, and he, in our discussion, felt that it was likely. Yeah, I think that was interesting. I hadn't seen Charles Bonnet syndrome before. Also, other differentials to consider for the hallucinations was this, to clarify that I think the Charles Bonnet syndrome is more so those hallucinations of bugs on the floor and the things that happen in her periphery, but that hallucination of a person in her room, to me sounded a lot like a hypnopompic hallucination, like the hallucination that happens just as you are waking or just as you are falling asleep, which I know can be increased in times of stress, but she had an identifiable social stressor. Also on my differential was Lewy body dementia or Parkinson's disease. And actually it's quite great that we had that Parkinson's talk, because we see that like the MCI can come and go depending on the disease prognosis, but she didn't really have any other Parkinsonism features, so that was lower on my differential. I didn't think that she had a new psychiatric disorder or psychotic episode. She didn't have any delusions. I didn't think it was depression with psychotic features, just because her geriatric depression screen was negative. So I think I'm leaning more so in the first two differentials. We had recommended that she follow up in 6 months for progression. We'd love to repeat her RUDAS or some other kinds of cognitive testing, and monitoring for symptoms of hallucinations. How are they progressing, and seeing if she develops any Parkinsonism features. We also, she had meant to follow up with her ophthalmologist, but she unfortunately had to cancel that appointment. And so was hoping that I'm hoping that she can be plugged in with her ophthalmologist too, to see if he has any other things to help evaluate or treat Charles Bonnet syndrome. And I guess some overall assessment that I have with this case is that sometimes our cognitive assessment tools, they're blunt instruments, but they don't always capture the cultural nuance of diverse patients. And the things that I'm just walking away with is like what are ways that we can try to accommodate for different cultural experiences of cognition and functional status.
Thank you so much, Christina, Dr. Orby. That was fantastic. And what an important point, and how nimble you were in kind of meeting her and creating prompts which you thought would be more, salient to her and more direct to her lived experience. So wonderful presentation, and so much care that you're bringing to her and her family. And so I'm curious from the community, what comments or questions are there for Christina? Yeah, Chris.
Well, as people are thinking about it, I want to commend you for really deft adaptations during the RUDAS. I mean, and Dr. Torres is welcome to debate me here, but I don't think comprehensive neuropsychological evaluations are definitive statements about people's cognitive functioning. They're snapshots in time, and screening measures are even more of a snapshot and subject to a whole bunch of noise, including when somebody has 0 years of formal education. So my encouragement to you would be to document what you did very carefully. And if it's not you who does that 6-month follow-up, whoever it is does exactly what you did. And now you've got, the spirit of neuropsychology of standardization for this behavioral sample of this individual. But really lovely job in terms of modifying on the fly, honoring this person's context.
I would agree with you, Chris, and I'm not debating you whatsoever. This is a challenge. At Harborview, we see a lot of patients for neuropsychological evaluation who are non-English speaking. So we work with interpreters. I am Spanish speaking, so I see Spanish speakers. And although we do have more measures that have been developed in the Spanish speaking community with normative data, it's still not sufficient because of the functional piece, right? People live in this country, and most of the time they never learn the language, so they don't pay bills. They're not in charge of their own medications. They rely on family for appointments, and so getting an assessment of functional decline is very challenging. So oftentimes, I see these folks for serial testing, which seems that is something you've elected to do, because that will give us a better understanding of changes over time now that you have a baseline. So great job.
Thank you.
Anybody else with questions or comments?
The only other thing I wanted to add that I forgot to was that jump from 18 to 24, 26. You could conceptualize that as, oh, maybe that's fluctuations with Lewy body, but I think the more parsimonious answer is this is somebody with zero, kind of experience with testing or very little experience with testing, and just that kind of practice effect, which bodes in terms of cognitive functioning. That's not uncommon for some of the folks that we see to do that much better the second time around, which makes you wonder, did she really even have MCI the first time? But that's maybe less relevant.
Yeah. No, that's a good point.
Brock.
Yeah, I would definitely question that MCI diagnosis. I think that was and the thing that struck me from the slide that you showed there was when you said no functional decline. In terms of I'm always confused what we mean by that, because I think if you're talking about ADLs, then that's one thing, and that's to help to differentiate MCI from dementia. But to me, it's so important to never make a diagnosis of MCI just based on a snapshot cognitive test, and that you need to kind of include, weave in input from an observer or informant, or whatever you're going to call them. I don't call them informant, I call them observers, to say, so that it gets a little bit more than function, which sometimes we think of as activities of daily living, as much as, are you noticing changes in the way that that person is sort of navigating through the world? So they may be fully independent still, but they're doing things like asking you the same question 30 minutes later, or they're having difficulty completing sort of a complex task that used to be easy for them, or they're becoming disoriented in a place that they should know well. Those are things that people can still be functional in terms of, they don't have dementia, but I really feel like it's important to get that sort of observer input to put it together with a cognitive test, and never to diagnose MCI based on a cognitive test.
And your point about having a good collateral history, I think was a limitation in my encounter, because the person who would have the most collateral history would be her daughter, who she lives with, and her son only sees her occasionally every couple months. So I don't know that he would be the best informant of monitoring her cognition over time, at least in the day-to-day sense.
Well, we are just about a minute after, so fantastic. If there are not any more pressing observations, thank you all for this really rich echo. And please do take the time to complete the 1 minute post-sesh survey. And again, thank you both to Karen and Christina. Outstanding. We'll be curious to hear, Christina, too, when you follow up, too. Please do bring back and update us. And perhaps the daughter will come so you can get a better parallel history. Yeah.